Please join me in welcoming the Honorable Garnet Coleman and the Honorable John Zerwas. Gentlemen, thank you again for being here, and especially, as President Powers said, in the fourth quarter, we appreciate you making time to leave the field temporarily to be with us. I want to begin with a broad question related to the 83rd session, which again is the end is in sight, but we still have work to do. Representative Coleman, has this been a good session or a bad session, generally speaking, for healthcare policy?
Generally speaking, good. And that's because there's a lot of attention on mental health. Right. And there wasn't as much attention on it in the last so many sessions, and right. There's actually dollars being spent. So that's a very good thing, because those are people who are left out of the equation. And along with the 1115 transformation waiver, we should be able to cover most people with, or at least provide them some care. So that's good. I think if you look at women's health, there's money that you put into the budget, and that's about $150 million, I think, right. Something like that. That's a good, really good chunk of change to deal with women's primary care. Yeah. I could go on, but I know that that Chairman Zerwas, he chaired that subcommittee. They've done an excellent job of making up for past losses. Yeah. So it's been good.
Good. Chairman, to the uninitiated, you'd be forgiven for thinking that the only health care issue being litigated this session was Medicaid. But as Chairman Coleman says, the reality is a lot of other stuff has been done maybe a little bit below the surface.
Oh, correct, exactly. And thank you, Evan. Always appreciate the opportunity to be with you all in Texas Tribune, and also with Chairman Coleman, who it's always an honor to get to be on a panel with him. He and I work a lot together in the legislature, and we consider a lot of things that need to happen in the legislature. Yep. But he's a tremendous help, especially to me, being somebody from the other side of the political spectrum and coming up with common sense solutions. But we have, if you look outside the Medicaid issue right now, which I'm sure we'll talk a little bit about later,
soon
we were able to make up for a lot of things that were a consequence of the very lean session we had last time. Right. And so we were able to address some of the women's health issues. Not only did we drop out of the federally funded women's health program, we then created the Texas Women's Health Program and fully funded it with our own general revenue at the same level under the provisions that Texas felt was important to provide that care. We have addressed the women's health issue in terms of all that 170,000 or so women that got bounced out of all the efforts around the family planning issue last time in the last session. A lot of women got bounced out of some of the very important primary care that they needed. So what we did was create this new program, as Chairman Coleman mentioned, called the Community Primary Care Program. Put a large amount of money in it, in excess of $100 million, as did the Senate. And though I'm on conference, the fact is we're right on the same page.
You're pretty close, right? Yeah.
Yeah, it's almost a non-conferenceable item, because we purposely made that the same, because we wanted to basically send the message. This is a priority for the Texas legislature. Yep. We recognize that there were some consequences to basically depleting the B13 or family planning strategy in DSHS, the state health services. And this is how we come about, saying we need to rectify that. Yeah. And this is a good remedy.
So generally speaking, you're as optimistic as Chairman Coleman is about the state of things. You think that
money is a great therapeutic agent, I'm telling you.
Right, yeah. It may not be the only agent, but it's a good agent,
right? It's a good agent. Yeah. We have a lot of money on the table this time. We had nearly $9 billion more than what we had budgeted for. Granted, it was a lean budget. Yeah. But we also had nearly $12 billion in the rainy day fund, at least monies that we would anticipate.
And it looks like you actually may spend some of it this time.
Well, I tried to spend some last time, and I wasn't very successful. But it's amazing how 2 years changes, that all of a sudden it's okay to spend that money on future obligations. But it wasn't okay 2 years ago. Okay, fine, I understand that.
Right, just take it.
But look, I'm going to take it and run with it. I'm not here to criticize. It's just an observation. Right. I like what the conversation is around using that rainy day money for what I would categorize some mega issues out there.
Fill in some holes, right?
Big holes.
Yeah. Now, it's good to hear optimism as a way to start. I want to acknowledge, though, that we talk all the time about a healthcare crisis in this country and a healthcare crisis in this state. Chairman, I'm tempted to ask you if you agree that there's a crisis, but you chair the Legislative Study Group, which put out a report recently called Texas on the Brink. And it was hard not to feel really bad about where we are reading that report. We're 47th in this, we're 50th in that, we're 48th in this. You do believe, Chairman, that we have a crisis of some proportion to deal with?
Yes, I do.
Yeah.
Particularly in education and in healthcare. It's a matter of covering individuals. And if we don't do the expansion of health coverage to adults, whether it's through a private system or through Medicaid, we'll leave about 1 million people without coverage. I think we also have some lean times based on some provisions in the Affordable Care Act that will reduce the amount of disproportionate share funding for our hospitals around the state. Chairman Zerwas and I and Chairman Pitts and Chairwoman Colcourse have worked on that to make sure that we keep hospitals as whole as we can.
Yeah.
But yes, I mean, that's a lot of money to leave on the table, and it's a lot of people to not serve based on the need. If anybody looks at this the right way, we're the biggest beneficiary of the Affordable Care Act, and we should be the state that is taking the most advantage of it.
Yeah.
So just laying it out under health care, I think there's some things that we could do differently. But again, we're making some ground this session.
Right.
We just don't know about the health coverage.
And we don't yet know how this is going to get resolved.
No, we don't.
Right. Chairman, the numbers that I saw last, and you could find different numbers from different sources on any given day, but the numbers that I've seen that seem to be credible are 28.8% of the population is now without insurance, not counting the underinsured or the uninsured. Not counting the underinsured or the underserved. 28.8% without insurance, 6.2 million Texans in a state of about 26.5 million people. That should concern us.
It should, and what I would say is I'm not sure we're in a crisis or that we're in an acute illness, but what is more frightening to me is that we are in a chronic illness. We've gotten so comfortable
this
with
problem
that,
goes back. It goes back many ways, right? Yeah,
that people are saying, well, we're really not doing that bad, and to me that's a frightening thing because eventually, just to practice medicine, eventually a chronic illness can have a very, very substantial impact and evolve into an acute situation. And so, right. What concerns me is that we have been at that level for so long. We are seeing the economy rebound in Texas, and that there may not be a sense that, well, this is a real crisis. You don't have to look too far to understand the crisis nature of it, and this is the thing that I think that we get a little immune to, if you will, and that is that if you remove all the other variables related to health care, the genetic variables, ethnic variables, racial variables, and look just at the issue of do you or do you not have insurance? Do you or do you not have some sort of money that can help you access insurance?
Yeah.
The incidence of disease that is further along in the stages of chronic illness, if you will, is much worse. And the most glaring example I remember clearly was in Houston a few years ago. And it was a woman who had a very large fungating breast cancer, obviously stage 4, that was uninsured, who had tried on multiple occasions to try to get in to be seen and do other things. At some point, you got to work, you got to make a living, and you just say, well, maybe if I just ignore it, it'll go away. That's the kind of thing that health insurance can do. It can create better access for you to get health care. It can't make you get health care.
Right, but it gives you access.
Certainly can break down those barriers.
Right.
It's those day in and day out stories that I think we need to look at to help us realize that, as Chairman Coleman said, we do have a crisis. Yeah. There is a crisis, but we get so immune to the numbers. 26 million people, 6 million uninsured, 1 in 3 in Houston are uninsured, 1 in 4 in the state are uninsured. But you start to put a face on that as to what that looks like.
Harder in the abstract, though, to appreciate.
And then you start to say,
right.
Wow, what can we do about that, and what is the unique opportunity we have now to do something about it?
Now, you have actually put your own credibility out there this session in attempting in various ways to come at some solution to the problem, while saying, and we take you at your word that you're opposed to federal health reform in the main. You actually want to get at some of those dollars that may be available to help us solve the problem. I want to ask you, as a matter of political reality, aren't you dead in the water this session? You may not be able to get the votes. I mean, really, practically speaking, Chairman, you may not have the votes in the House. Even if you have the votes in the House, you may not have the votes in the Senate. even if you don't have the votes in the Senate, the governor surely has signaled every intention to veto anything that looks like or smells like or tastes like an expansion of Medicaid. Is it, as a practical matter, legislatively, the issue of leveraging federal dollars for this purpose more or less dead?
Well, you framed it in a way that probably I wouldn't, being the eternal optimist. I'll say, you know, what I would say is this: we got it out of the Appropriations Committee, not with great glory, but 15 to 9. I probably would have had a few more votes had certain other people been at that meeting. So I was comfortable that we had a solid majority of people that were supporting this, and every no vote in that committee was punctuated by, I really think what you're doing, I admire what you're doing, I just am not ready to support this, you know. Yeah. And that's the struggle that a lot of people are having around this issue. So we're hopefully in calendars, the committee that ultimately decides what comes to the floor. Yeah. We got until midnight, May 8th, to get it heard as a second reading. That's a good number of days away. Yep. The Speaker, I know, is very interested in having this bill heard and having that conversation on the floor of the House. He is really with you in some respects, right? Oh, really, on this particular bill, all respects. Yeah. Because the Speaker is quite clear. He feels that this is something that at least the Texas House of Representatives ought to get caught talking about, because it is one of the headline issues out there. Even if the Senate won't go there, even if the governor won't go there, you all want to put your stamp on it. Exactly. And so the fact that, yes, I had the hearing and I had the support in the appropriations, that's a win. It's not the win that I ultimately want to have. You've described, you know, where I'd ultimately like to see this bill get, and that is to the governor's desk. You know, the governor may or may not veto it. I would weigh in with you on the odds that it would get vetoed if it got that far. Yeah. I do think, though, that it would receive a warm consideration in the Senate in my conversations with leadership there. You have more optimism about the Senate? Oh, absolutely. Because when you look at this, and it's House Bill 3791, the only bill that the legislature has the opportunity to have a conversation around right now is 3791. Because the Senate did not pass a bill until the deadline came, and then what they did was scramble to put in some caveats, if you will, in the appropriations bill, Senate Bill 1, which is good. I mean, at least says that, yeah, we're thinking about this, and this is the principles that we think that you ought to incorporate if you're going to go up to CMS and try to negotiate a deal. A lot of those principles are in House Bill 3791, which I want to say, you know, Chairman Coleman is a joint author on that bill, and that's very, very powerful for us. So this is the vehicle. This is it. This is the vehicle. Right. You know, the members need to have a conversation around this, whether it passes or not in the House of Representatives. Right. I believe the public expects us to have a conversation around this. Right. And if you talk to any of the other, you know, folks out there, whether it be the county officials, the medical, you know, constituents, the hospital constituents, the chambers of commerce, business community, right? Yeah. Everybody is solid behind. Go do something. If it's not Medicaid expansion, fine. Go do something. And we as a legislature, and certainly we as the Texas House of Representatives, need to have that conversation. Right. Chairman, the prospects for this bill in the House, they don't sit on the shoulders of Democrats. My very real belief is that your 55 Democrats in the House are likely to be with Chairman Zerwas. This is a Republican on Republican issue, by and large, is it not?
And it has been. Yeah. Sort of like immigration, you have the social conservatives and the business people. One wants a continuation and the other no. Yeah. I think that if I were to do anecdotally the number of Republicans who've talked to me and said, you have some solution, don't you? I said, yeah, I do. I think that ought to be a signal that most folks want something to happen in their communities, particularly communities that aren't as wealthy as other communities. Mm-hmm. And I remind people that if we really care about people with cancer and we spent $3 billion to try, or we're going to try to find out if we can cure it, then we ought to do this, because we're using somebody else's money, and cancer is the most, the benefit the most will be people with cancer. Under the Affordable Care Act.
Right. Why, Chairman Zerwas, you said that there are Republicans on your, I'm assuming there are Republicans on your committee who said, I can't get there. I support you in theory, but I can't get there. What is their objection?
There's a couple of them. Some are just very ideologically entrenched that I don't want to take any more federal money to expand any government health care program. And I respect that. That's just a belief, philosophical presence that they have, and I'm not going to move them on this bill. This bill is designed to draw down the very, very large amounts of
exactly
money
what they
from
hate.
the federal government, and they don't want any part of making that bigger. I can't move those people because I say very clearly, as conservative and as Republican, if you will, as this bill is written, they still can't get there because ultimately it takes federal money.
Right.
That's not the majority of them. The majority of them that I talk to is that I'm going to get framed on this in March of next year.
So this is about getting primaried.
This very much is about that.
Profiles and courage.
This is this is about, you know, I could see the flyer going out. You know, Zerwas is all about, you know, facilitating the growth of Obamacare. You know, is this the person you want representing, you know, your district? I can see that. You know, I'm not afraid of that. You know, I carried the exchange bill last time, and again, Chairman Coleman was on board with me on that.
Got reelected.
And it wasn't even an issue. You know, in fact, it was more about the people who I did have hearings with and met in public were really appreciate you carrying that bill. We understand what you're trying to do, and we're with you. And so, as I talked to people, I said, you know, yeah, there's going to be some people that are going to frame you that way out there, but you go talk to all those groups of people that I just mentioned to you, and it's everybody that lives in your district is somehow connected to all those groups, and they're saying do something.
Right.
I say, if you don't want to do Medicaid expansion, fine, go do something.
Go do something.
And that's what really 3791 is about. It's about opening the door for a conversation in Washington, D.C., that people who can walk through that door, i.e. the gentleman to my right, can go in there and actually have a conversation about what this opportunity
make the best deal that we can get.
And make the best deal out there.
Right.
And so we need to take advantage of that. Not every state has that kind of access. We have that kind of access as a state.
Right.
And what we need to do is to just basically say, as a legislature, to the commissioner, our commissioner, and to the governor, say, let's go up there and negotiate something. And you've got the strong horses that can make this happen.
Well, I want to come to the notion of you and the commissioner going up to D.C. in a second, but I want to ask you, Chairman, if there's a backdoor solution here.
No, I didn't open that conversation.
I understand.
Okay,
No,
I want you to say.
I get it. No, that conversation was already taking place, as we now know. But Chairman Zerwas, I want to ask you about whether there's a backdoor solution here by way of the budget process. I mentioned that you were named by Speaker Strauss as one of the 5 budget conferees from the House. There are 10 of you in total, 5 from the House, 5 from the Senate. The House took a non-binding vote the other day, offering instructions to the conferees, and by a vote of 77 to 68, non-binding, the House said, we don't want you to do anything in the budget conference that smells like Medicaid expansion. But again, non-binding. I look at the conferees on the committee, Zerwas, Sylvester Turner, Jim Pitts on the House side. On the Senate side, I see Hinojosa, Whitmire, Williams, Duncan, Nelson. That smells to me like a lot of potential votes to disregard the instructions of the House. Those are some people who I could actually see, left to their own devices, doing something that maybe gets you there through the back door. Is that the end game here, Chairman?
Well, you know, one of the you characterized it well. There is I spoke against that directive, as you may know.
Right.
And the reason I spoke against it is that the conferees need to have the ability to talk about what the fiscal impact could be to any kind of expansion of health care that would draw down the federal dollars.
Right.
If you strictly want to talk about do not do anything that has to do with literally anything with Medicaid expansion, I don't have a problem with that. Now I know Chairman Coleman would be fine with that, you know, but I
Call
would
it something else.
I would be fine with saying, okay, I'm not going to talk about anything that would be basically an expansion of the program that I consider quite fragile right now, that would throw another million and a half people into it. I'm not supportive of that without there being some very fundamental changes to the current program. Right. So therefore, what we have in the budget right now is the Senate's rider that basically lists about 11 principles that would be considered important in negotiating anything with CMS. A lot of those are in 3791, as a matter of fact. So for us to have the conversation, at least, around what the fiscal impact in the budget would be, I don't feel that that's problematic for us to do that. What would be problematic in the budget, I think, is to try to create, and it's really, you can't do it, is to create law in the budget, which I think largely this is a policy issue. This is an issue that the House and I would hope the Senate need to have a real conversation around, because when we come back with the budget, as you know, it's an up or down vote. You're not going to have a conversation about Medicaid expansion in that vote. You may have some people get up and say, well, we don't like what you did here, and we don't like the fact that you had a conversation about, any growth of health insurance in Texas. Right. But the point is that the appropriations budget is not the place to have a really robust conversation around an issue like this.
And Chairman, you've been in the legislature for a long time. You know that when you load up the appropriations bill with something so controversial, it may actually insulate you from those no votes, because it forces people to vote against the entire budget.
Or vote for the entire budget.
Or vote for the entire budget,
because,
as the case may be.
And the reason being is in that same budget will be the water money and the highway money. And people want
money for education.
Money for education. People want those resources to go to solve problems in the state.
So maybe baking into the cake something that is not called Medicaid expansion but accomplishes many of the goals you want, that may ultimately be a way at this.
Yes.
Yeah.
I mean, you get it how you can get it.
Right, yeah. First law of politics, right? You get it how you can get it.
But it's not unprecedented.
Yeah.
I mean, the 1115 waiver was done by Ryder.
Yeah.
Transformation waiver, and it's worked out well.
It has. Chairman, you mentioned exchanges. Correct. And you mentioned the fact that you carried exchanges back in 2011. You, at the time, said very explicitly, I am not for federal health reform, but I want to set up a state health exchange, because if we don't, the feds are going to come in and do it for us, and we don't want that to happen. Isn't that, as a practical matter, what's going to happen now, since we've said we refuse to create a state health exchange? In a state where we say we don't want the federal government coming in and doing our business for us, we have effectively opened the door and invited them to do just that.
Yeah. Yes, I of course am disappointed that we didn't ultimately create and own the exchange, because I think, again, an exchange is just a way to operationalize something. Yeah. The Healthcare Reform Act really requires an exchange, whether it be federal or state, to operationalize what they're going to do.
It's going to happen one way or the other.
Especially with these 200 to 400% subsidies or credits, tax credits that people are going to get. The exchange is a logical way to do it. Right. States have had exchanges in place well before Healthcare Reform Act came to being. Yeah. If we got a block grant, which I'm a big advocate of, if we had gotten a block grant, or if we did get a block grant in the future, we would incorporate an exchange as a mechanism to help implement that program. Right. I have no doubt about that. What we're looking at right now in House Bill 3791, if we were able to get this waiver to provide insurance to this group of people under 138% of the federal poverty level, we would use some kind of exchange process to make that happen.
But in the absence of that now, the feds are going to come in. It's going to cut out our insurance commissioner, whether it's Eleanor Kitzman or whoever else, from having some supervisory role over this. I mean, we really are turning over the controls to a large degree by way of not creating a state health exchange to our sworn enemy, the federal government. Is that right?
You framed it very well. That is the way it exists right now. And regardless of some of the conversation around it's the Fed's rules that the state would have to implement, the state would have to pay some money to do it, blah, blah, blah. Yeah. The point is that I share exactly that perspective. I am very uncomfortable ceding anything as important as our insurance market, not just the health insurance market, but the camel's nose under the tent, to the federal government. I think that should be maintained as the sovereignty of the state. Right. Now, we can take that exchange anytime. Yeah. The Healthcare Reform Act allows for that to happen. We can take ownership of that exchange anytime. I would hope and anticipate that would happen. I think that at some point we will have the exchange under our own auspices, and I think that may be something that, as we look to the future and hopefully get up there in CMS and negotiate some things, if there are issues around the exchange that we need to consider, let's put those on the table.
Let's go there.
And maybe those are things that we can talk about as we start to sort of define this Texas solution.
Now, Chairman, you actually don't share the fear of the federal government creating an exchange or the federal government being on our soil.
I don't share the fear, but I do share the idea that we should be doing it. And the reason is it'll work better. If you put Medicaid or whatever the program is that we do in with the private health insurance, or if we have it all private health insurance, that means people go to one place. Under the federal exchange, people would go to two places. Yep. They'd go to the exchange, and then they would go to Health and Human Services Commission. Right. And I really do believe that's the reason why we're not doing it. Why? Because Medicaid would be in the exchange. Yeah. Which means that would be a simpler way to get people eligible to get health insurance in Medicaid. In the end, all roads lead back to the same issue. Of course. Yeah. Yeah. Can I ask you about this notion of you going to Washington on behalf of the state as an envoy of sorts to work with the federal government? There was this really interesting story that Bob Garrett wrote in the Dallas Morning News a few weeks ago about you and Commissioner Janik seeming to plan a trip to Washington to go to negotiate with the administration. You were texting back and forth like 15-year-olds. In fact, Garrett had the OMG, maybe we'll see Obama, smiley face, smiley face. I mean, it was, you and the commissioner were texting, and the minute that word of these text messages and the plans to go to Washington got out, all of a sudden, trip canceled. Can you shed a little light on exactly what happened here? Well, you know, unfortunately, we didn't get to make that trip yet. But I believe there needs to be a discussion, or at least a shake hands, nice to meet you, discussion in Washington. Do you think that might still happen? I hope so. I mean, you know, whether it happens during the session or not is another story, but I do believe that. I don't believe that we can keep going down the road, talk about something that we may or may not do with the federal government and not talk to them. And so I thought that it would be important not to have a negotiation. That wasn't the deal. It was to have a meet and discussion. Yeah, a discussion, a meet and greet. Wouldn't it be a good idea for Secretary Sebelius, for instance, to have some sense of what it is that we as a state are prepared to offer in the way of let's work this out, or for that matter, for Secretary Sebelius to tell you all, here's what we, from the administration's perspective, are prepared to offer Texas, so that politically people who don't like us can save face, or that practically speaking, if there are certain things you'll accept but other things you won't. I mean, they negotiated pretty heavily with Rick Scott in Florida to get him to a place where he was willing to accept this deal. Shouldn't we be in some conversation with the government, even if we don't like them, just to understand? Correct. Well, and House Bill 3791 is all about that. Yeah. It's about basically sending a directive with what we think are important issues related to health care, and go up there, let Commissioner Janik go up there, and perhaps Chairman Coleman and others that can open the door, who are deeply involved in this or have the political entry into that area, to have the conversation. There just needs to be a conversation. And like Chairman Coleman said, I don't know that it'll happen under the spotlight of the legislature right now. You can't invite Secretary Sebelius to come down here like Nixon in China and testify at the legislature and give us an opportunity to be in dialogue with her? I think we want to pass the bill, so I think I would probably choose to peace. I get that. Okay. Maybe manage that a little bit differently, but okay. I think, how's June 15th sound? Right. Yeah. Pass sine die. Before we open it up for questions, we'll have a few minutes for questions from the audience. Let me ask you, because of Medicaid's glare being so bright this session, we have not talked about a lot of other issues that I suspect you both would have liked to see get more attention. You mentioned mental health. That's a good one. We did do work on that. We did do work on women's health. But surely in the entire portfolio of healthcare issues, in the absence of this sense of Medicaid sucking all the air out of the room, there would have been work that would have been done, or things that would have gotten more attention. Can each of you talk a little bit about, in a perfect world, what we would be talking about if we were not talking about this? Chairman Zerwas first. Well, you know, certainly that is one of the things, though, that we are talking about that is continuing to get attention, and I have every sense to believe that we'll have a remedy, is graduate medical education. Yeah. It's an area that... Of no small consequence on this campus. Correct. And of course, we're opening new medical schools here in Austin, down in the Valley. We educate doctors that get an MD, but they can't do anything until they do graduate medical education. Yeah. And there is, at least in a lot of states, an 80% chance that where they do their GME, that is where they'll stay in practice.
And therefore, you know, the state of Texas becomes great source of doctors for other states because we spend all the money to get their medical degree, but yet they go and train elsewhere.
Frankly, it's an economic development issue alongside the health issue, right?
Exactly. And so we do have something baked into the budget that as a conferee I plan to pull out. I think that it will mesh very well with the Senate expectations. The primary issue is what's the source of sustainable funding that can allow you to expand these slots. I think we've found that. I think we have defined the way that these slots ought to be allocated based on need. And I look forward to that, you know, actually coming to fruition during the budgeting process. So.
Good. Chairman, but what should we be talking about that we're not talking about?
Well, first of all, I think the GME is important. We have it in the 1115 transformation waiver as well.
Good.
So that's a good thing. I guess, you know, I think we're making headway in a lot of areas. I guess the place where we have a sticking point that is sort of talked about is the IGT and the 1115 waiver versus IGT in DISH.
Help for the benefit of the audience.
Intergovernmental transfer.
Unpack those acronyms, okay.
Which goes up to help draw down DISH funds, disproportionate share funds for public hospitals, and which is shared with private hospitals. And then you have the same kind of IGT that goes to do the 1115 waiver. So there seems to be a disagreement about what proportion of IGT should go to DISH versus the waiver. I think we're working that out. But I think it's one of those sleeper kind of deals.
It also seems like not a terribly ideologically charged issue. It seems more mechanical than political.
It's mechanical. It's about money.
Yeah,
it's commerce.
Right, it's commerce. Right. Nothing else, though. I mean, my intuition, Chairman, is that the last couple sessions you may have had a longer list of things that you wished had gotten dealt with that didn't. It has been a bit, we said before, a bit of a kumbaya session on a lot of issues, hasn't it?
Well, I mean, I guess I've narrowed my point of view, quite frankly, and I'm looking for successes and making sure that we can do what we can do.
Right.
And based on the work that has been done in the Appropriations Committee, I think that's extremely important that funds have been put into in areas that I thought was important. I mean, I worked on the Women's Health Services waiver, passed it twice, vetoed once by Perry, once by Bush. So to see this primary care initiative to help women with their primary care, I just think, you know, that is phenomenal.
And you're reasonably sure that this gets through, the governor won't veto it?
The budget?
Women's health, any of the women's health stuff that you all do?
Oh, absolutely. I think this is all baked into the budget. It's well within our spending limits.
It's blessed, basically.
Yeah, and the Senate and the House are right together on that. So
magnificent.
Yeah.
Good. All right, let's open it up for questions. We've got about 15 minutes before we end this program and take a little break. So anybody who has questions, Natalia in the back has a microphone. We can walk it around to you. If you prefer to stand up and use your outside voice, there are few enough of us in here that you can probably be heard. Ms. Richards first, right there.
Although there has been an increase in funding in the Women's Health Program,
here's a mic for you.
What can you do to address the closing of the clinics in rural health so that although there may be money available, there is no access?
I'll let either of you jump in on that.
Well, I'll start. There are two pots of money. One pot of money is the new money in the appropriations bill, and the second pot of money is Title X. Some of you all may not know this, but a group of people went here from Austin and applied to have Title X sent to them. And that's going to replace a lot of dollars that went away, both in the waiver and then the diverting of family planning dollars. The great thing about the money that's in the appropriations bill is it's broader than family planning. And Title X can be as well. That's a significant thing. And so there should be enough money to replace those dollars that came out of the budget to keep rural health care moving forward. Now, of course, if we had the Medicaid expansion, it wouldn't even be a question. All of those women would be covered under whatever plan we had. And that's the big deal. Right. But at least something has been done that took into consideration that was an important public policy issue that we should resolve, or at least have women get the care that they need.
Chairman, why was this issue so much less of a hot potato this time?
Well, I think one, as we looked at the particular part of the budget that was depleted, where that effort was made, there wasn't a lot of money put back into that area purposely, because we said, look, the only way we're ultimately going to be able to restore these women's services is to create a new program and call it something else, and that's the community primary care, and put a lot of money into it. In fact, more money than what was in the other area of family planning, which was a bit radioactive. And we left that the same. But the chairman makes a good point about this Title X money, and this is a little technical, if you will, but that Title X money was coming to the state because we applied for it and got it. But the state didn't have a monopoly over that. Other people could do that, and in fact, other people did, and they got that money. So that money left that part of our budget. But at least on the House side, what we said was, in the event that that money goes away, which it did, we can borrow money out of the Medicaid strategy to fill that money, because we didn't want to lose any more of our providers in that area who met all the criteria that we had established. That was a bit controversial, but they were there, they were approved, and they were doing good work on behalf of women. We wanted to keep them in business. So the provision in the budget was, if you lose Title X, and we did, draw down money from the Medicaid program, which we know we always have to pay, and keep these people whole. So there's been that effort to do that. There's the new program around community women's services, the new Texas Women's Health Program, which is $40 million, $40+ million, that Texas put their own money in because we got sideways with the federal government on the rules around the federally funded women's program, a 90% federally funded program. We walked away from it and said, you know, we want to run this program under certain conditions that we, the state, feel are important. And so we went and created our own.
And you're satisfied 4 months in, Chairman? There was some controversy at the beginning of the year when the switch took place, that there perhaps were not an adequate number of providers in the state's program versus what was available in the federal program, that there were some providers listed who actually couldn't provide the same services that providers had provided in the previous program. You're satisfied that 4 months in, those kinks are being
I can't say that they're completely worked out, but that certainly that is the ambition of that program and all the other programs, such that rural health isn't left out. Lots of money coming in, the 1115 waiver that the chairman already mentioned. And I know a lot of this is just kind of a mishmash of things, you know. But what I think what it really says is there is a lot of money coming into Texas. There could be a lot more money coming into Texas if we do something to negotiate some money for this new population that could be insured, you know. So we're in a good position, and as the chairman said, there's always the ripple effect in the economy in terms of the positive economic impact that this has. I always just define that as that, you know, that's just the collateral that occurs by virtue of doing all the things right that you want done right. Yep. You know, this is the dividend, if you will, that comes from doing these things. And so, you know, I think those things could, I think all those things could happen. And as much money as we have sort of plowed into these things, we could even do a whole lot more if we really got something negotiated around this this new population.
Ma'am, let me let the chairman say a quick word.
Just to add to that, you know, that came from one of those trips to Washington, the Title X change, and also the delaying of the ending of the federal program came from one of those trips to Washington and some letters that my congresswoman and I sent and some meetings that we had. So it does work if you can have conversations with people and they can tell you how to best fill those gaps. So that was a nice trip I took, and came back. It was very successful.
It was you, right? Not we. It was
no,
you.
It's well, me.
Okay, well, I just want to be sure that we know.
Sheila was already there.
If we were going to uncover any additional secret meetings, I thought we might just do it right here. So.
No.
Ma'am.
I appreciate being here. I'm Brenda Coleman Beatty, and I'm here with my healthcare advocate hat, even though I serve as a board member of the Travis County Healthcare District, also known as Central Health. Yeah. As a proud Texan, I think we all love to declare and claim our uniqueness, and sometimes our pride gets in the way, which leads to my question. And that is, during the legislative debates that have been going on and discussions, was there any consideration of other models to create a patchwork quilt to embrace other people into healthcare? For example, aside from Florida, was there any consideration of what Arkansas did?
Right, we've heard a lot about the Arkansas solution.
Well, I mean, I think that 3791 has components that mirror the Arkansas solution in that it's private insurance for those populations, and that's what the chairman put together because it's not Medicaid. And that's important to understand because the governor has said he doesn't want to expand Medicaid. And that does not expand Medicaid.
I would, say that we really looked for a unique solution that would allow us to perhaps manage this population differently. I almost look at it as like a pilot study. Let's take this 1 million to 1.5 million people that for which we don't have a solution for right now, and figure out a way that is sort of compatible with the spirit of Texas, in general, and let's see if we can make that work. The Arkansas plan gets kind of a headline out there. It's a one-liner, beneath which there should be mountains of information that says what works and what doesn't work. And again, I think this is the idea behind 3791 is to try to let's put something out there, and as Chairman Coleman said, let's go up and have a conversation. That is the main thing that needs to come out of this. Let's go up and have a conversation because I think that CMS is in the spirit to negotiate. And so you can't negotiate, as Evan said, unless you go up there and talk.
We thank them very much for their time with us today. Chairman Coleman and Chairman Zerwas.